Good evening. What a jazzy intro. And welcome to the 74th season of the Amos Fortune Forum. My name is Sam Greene, and I will be moderating tonight's talk. Tonight is my honor to introduce to all of you one of my favorite cousins, Dr. William C. Torrey. We don't call him Dr. William C. Torrey around the house, of course, but Will, as he is commonly known by, or Willie, as he is referred to by his siblings. And I will say more about our family connection in a moment. I'd like to get this rather dense but brief paragraph about his qualifications and his work set aside. So Will is the Raymond Sobel Professor and Interim Chair of Psychiatry at Dartmouth's Geisel School of Medicine. He has obtained his BA in religion from Dartmouth College, something I was completely unaware of growing up. I'm about 4 years younger than he. And it came as a complete surprise when I was reading his bio. And he received his MD from Harvard Medical School. And then he trained in psychiatry at Dartmouth before joining the faculty there. As interim chair, he leads the teaching, research, and clinical missions of the Department of Psychiatry. He also practices psychiatry, promotes and implements innovative psychiatric services across Dartmouth Hitchcock's service system, and he trains others to provide evidence-supported care and applies his clinical administrative experiences to enhance research projects. Through all these activities, he seeks to extend timely access to sustainable, effective psychiatric services. One thing I would also add that I've known about Will is that he also served as the director of the West Central Community Services. It's kind of the region, the psychiatric region of the state of New Hampshire that exists between Claremont and Lebanon. Very much in the field, and I believe that that's really where he cut his teeth in his work. He also has served as the director at the New Hampshire, the interim director at the New Hampshire Hospital in Concord. What impresses me is that Will's career has been made up of clinical care, administration, teaching, and research. So Will has worked to integrate psychiatric care with primary care as sound medical and social policy. So tonight, Will's specific topic is Your Health Matters, Improving Access to High Quality Psychiatric Care. And I'm sure you will agree that a forum topic on the subject of mental health and psychiatric care is particularly timely in this year and in this state. I always find it interesting to make connections between an Amos Fortune speaker and his or her roots in Jaffrey or the Monadnock region. And in Will's case, this is a very straight line. As most of you will be aware, after graduating from Dartmouth in 1778, Laban Ainsworth became the town of Jaffrey's first minister, a post he held for the subsequent 76 years until his death at the age of 100 in 1858. Laban ministered in both Jaffrey Center Meeting House and then the brick church, now next door to the Meeting House. And it was during Laban's time in Jaffrey that Amos Fortune himself settled in Jaffrey, seeking to establish his tannery business. And land was provided by Reverend Ainsworth on Minister's Brook, which is just down the hill from the Meeting House, for this enterprise. Amos went on to be a respected citizen in Jaffrey and bequested funds to be used for education, which became seed money for this very forum. Fast forward 60 years, when a David Clarence Torrey arrived to become the first church's minister from 1918 until his death in 1932. His two boys, the two Torrey sons, William and Norman, fell in love with and married two Greene sisters. You may recognize some last names here. The Greene sisters' names were Dolly or Nan, or Ann Nan, otherwise known as Dorothy and Anna, and they were direct descendants of Laban Ainsworth. So Will's grandparents being the product of William and Dorothy, and my grandparents being the product of Norm and Anna, or Nan, there's a very tight-knit cousinly relationship between the Greenes and the Torreys. Even today, 233 years after the construction of the Ainsworth Manse, our two families and other Ainsworth descendants continue to share and use Laban Ainsworth's original parsonage and gathering annually for family meetings. So there, in a nutshell, is our cousinly connection. I'd like to quickly thank my wife, Tony Gildone, who serves on the Amos Fortune Forum committee, for the opportunity to introduce Will. And so, with that introduction, Will, the floor is yours.
Thanks so much, Sam. It was really, thanks for that nice introduction. It was quite fun to have you introduce me. So it's a great honor to have the opportunity to give the Amos Fortune Forum talk. Like Greg Cunningham, who gave a wonderful talk last week, I've been going to the Amos Fortune Forum talk since I was a kid. Sitting in the Meeting House, I've often listened with great interest to what the speakers have to say, but occasionally I've listened with great interest for the 9 o'clock bell to ring to let me know that the talk's finally over. My hope is that tonight you'll have the former experience rather than the latter one. This photo shows where I'm from, and it also shows where I'm going. My parents, aunt, grandparents, two sets of great-grandparents, cousins, ancestors back to Mary Minot and Laban Ainsworth, friends, as well as Amos Fortune are all buried here. Jaffrey Center connects me to my current family and also to the past. And it also reminds me that we're all just passing through. In our family, the names repeat and blend into each other, like in the book of 100 Years of Solitude. Another William, another Frederick, another David, another Laban, another Dorothy. It's comforting. Since I do currently have the virtual stage, I'm going to indulge myself in a little more family history before I get on to my real topic. As Sam mentioned, Laban Ainsworth's what ties us all together. The picture, the line drawing on the left, shows him when he was pretty old. As it says down in the bottom, and Sam mentioned, he graduated from the class of 1778 at Dartmouth. His biographer notes that he considered going to Harvard, but he didn't because of the trouble in Boston, which of course was the Revolutionary War. I wish I could be speaking in the same meeting house where he preached for so many years. But since I can't do that because of COVID, I think it's fitting that I'm talking to you from up at Dartmouth, where he was an undergrad. He also, I think, got a master's degree there. When he was an undergrad, he didn't have to deal with COVID-19 like the students did this whole last year. But he did have to deal with a different epidemic. When he was in college, the smallpox was coming through. One way to people protected themselves from getting smallpox was to inoculate themselves with a small dose and then isolate themselves while they got sick and hoped that they didn't die. Laban Ainsworth did this when he was in college, and his isolation was in a place called the Smallpox Hut, which I think was only about a mile from where I am right now. The photo on the other side is Frederick William Greene, Laban Ainsworth's great-grandson, and his family. F.W. Greene was an early photographer, and this is a portrait that he made of the family. And as Sam mentioned, he had two daughters who ended up marrying two Torrey brothers. The daughters are my grandmother, Dorothy Greene, down in the bottom, and Nan Greene right above her. I think it's just a beautiful photograph. So, if I were in the meeting house right now, I'd ask all of you to raise your hands if you yourself or someone you love had experienced a mental illness or a substance use disorder, or if someone you cared about had died from a drug overdose, or had taken his or her own life. You certainly would see my hand raised, but I think you would see just about everyone else's hand raised as well. These difficulties that I'm going to talk to you about tonight are common difficulties, and they're not issues that just happen to other people. They touch all of our lives. I include this picture of my children when they were young to bring the discussion home as really personal. Healthcare is personal. We want excellent care to be there for our children and anyone else we care about, including ourselves, when we need it. We want a system of care that expects us to turn up with these illnesses, is prepared, and welcomes us into the kind of care that's been shown to be effective. There is no health without mental health. So now I'm going to move on from these slides. So what can you expect from this talk? Tonight, I'm going to speak first about psychiatry in general to give you some brief introduction, then a little bit about my professional path that's brought me here, then a little bit about history of psychiatry in New Hampshire, which I found interesting, and finally conclude with some thoughts about the current situation and what next steps we might all take together. So to start with, psychiatry is the branch of medicine that studies and cares for disorders of the brain that present as emotional or behavioral difficulties. Examples of the kinds of difficulties that we treat in psychiatry include major depression, bipolar disorder, schizophrenia, post-traumatic stress disorder, obsessive compulsive disorder, panic disorder, eating disorders, attention deficit hyperactivity disorder, dementia, alcohol use disorder, opioid disorders, and many others. These difficulties are extremely common. About 20% of the US population will have a diagnosable significant psychiatric disorder in any given year, 1 in 5. And in our lifetime, about half of us will have one of these disorders. Major depression affects 1 in 5 women in their lifetime and about 1 in 10 men. About 25% of Americans will use alcohol in a way that puts them at risk in a way that is not healthy, that puts them at risk for accident or early death. These difficulties are not only common, but they're very painful. Major depression is terrible. People who have depression can't experience pleasure. They feel sad. The sadness kind of has a life of its own. People can feel bad physically, but they have trouble sleeping. They often have difficulty with eating. They eat too much or not enough. People lack energy, drive. They tend to think negatively about everything, most particularly themselves. People feel very guilty and awful. Sometimes it feels so bad that death feels like a better option than trying to slog through one more day. Other psychiatric illnesses are also painful in different ways. People that develop major manic episodes might feel elated and excited while it's going on. But if they spend all their money or wreck their marriage or lose their job, the devastation afterwards leaves them distraught. Psychotic illnesses that include paranoia and feeling like someone is after you or plotting against you are highly uncomfortable. I remember a patient one time who felt he had a chip put in his head and that a law firm 60 miles away was telling him what to do, and he just couldn't stand the feeling. They're painful illnesses. The illnesses are often disabling as well. The World Health Organization has found that depression is the most disabling condition worldwide. In healthcare setting or for employers, depression and back pain cause the most difficulty with work. Depression, people miss work, but also they come to work and are unable to do their job because they just can't get their thoughts going or feel so bad about themselves or don't have any initiative. The illnesses are also sometimes deadly. Suicide is the 10th most common cause of death in the United States overall. And between the ages of 10 and 35, it's the second most common cause of death. The first most common cause of death during those ages is accidental death, and that includes drug overdoses. It also includes car accidents that can often be alcohol related. In New Hampshire, about 5 people kill themselves each week, and about 8 people die of a drug overdose each week. That's a lot of people in a small state. It's hard to not know someone who's either died of a drug overdose or who's taken their own life once you've lived a little while. These illnesses are also very expensive. They are people who develop severe illnesses or recurrent illnesses often have a hard time making the money that they did before and have some kind of downward economic drift. They also cost a lot to treat. If you have depression and an illness like diabetes, the cost of care is about twice what it would be if you had diabetes alone. If you think about it, it makes sense that illnesses that require self-management, like diabetes, you have to watch what you eat, you have to exercise, you have to take medicines as recommended to have good outcome. And if you don't do those, if you're depressed, you often have trouble with the get up and go, the drive, the organization to do the things you need to do to take care of your diabetes. The extra cost turns out not to be from psychiatric care, but from the general medical illnesses causing more hospitalizations and more time in the emergency room. In addition to all these things being common, painful, sometimes disabling, often and sometimes deadly, These illnesses are also extremely treatable. People generally get better when they get timely, good care. I can't tell you how many people I've met who are doing really poorly, who've learned to manage their illness effectively and gotten on with life. It's almost baffling to think about how ill some people are, and if you met those people professionally on the job, you'd never know that they lived with that experience because they're doing so well managing themselves. So when I went to medical school, I really didn't know a thing about psychiatry. In school, I met some remarkable psychiatrists, and I also met some very interesting people who were living with psychiatric illnesses. I saw people who were really ill get better, and I found myself reading about psychiatry in my spare time. When I was in medical school, a childhood friend who was clearly suffering from depression took his life. That experience also helped me to push me to decide to go into the field of psychiatry. I knew that it was not only interesting, but very important. It was a matter of life and death for many, many people. So back then, when I was in school, mental illness and addictive illnesses were even more stigmatized than they are now. The choice of going into psychiatry itself was stigmatized, with many people trying to persuade me not to do it. Um, in my class of 160 students at Harvard Medical School, only 3 of us went into psychiatry. I had to give myself permission to do what I was really interested in. At the time, it was a very independent choice. I decided that psychiatry would engage my whole self. It would use my understanding of science, it would use whatever social skills I could muster, and it would use my humanity. I decided the work was important, and I went into it, and I've never looked back. I've been honored to enter into people's lives and to hear about what really matters to them, and to get the chance to play an active role in helping them to find their feet and get on with life. It's been very interesting and very gratifying. Psychiatry is a lot of things, but it's really never boring, and it stays interesting over the years. So after medical school, my wife and I moved to the Upper Valley, and I trained at Dartmouth. I remained very interested in the care of adults who had severe psychiatric illnesses. So, as Sam mentioned, I took a job at a wonderful community mental health center called West Central Services. Um, at that time, I worked really closely for many years with Phil Wysick, who's the CEO of the Community Mental Health Center in the Monadnock region now, and a wonderful person. At West Central, I cared for hundreds of people. I trained medical students and psychiatric residents, and I engaged with a team of researchers who were aiming to improve the quality of care in New Hampshire and across the country. Uh, so the care changed over time and in very gratifying ways. When I arrived at West Central, the main aim of care, and everywhere else in the country, was for people that had more severe psychiatric illnesses, was to help them to stay out of the hospital. The care was kind and protective, but it didn't support people to get back to work or to get to school. It maintained people. And when we started learning more about the experience people were having who were living with these illnesses, the idea of being maintained was seen as extremely demoralizing. People didn't want to be maintained. They wanted the same thing as all of us wanted. They wanted a life worth living. So at that time, I had a colleague who collected recovery stories or people's personal experience with psychiatric illness. And I just read piles and piles of these stories. And I started to see that there was a clear pattern. People that develop serious psychiatric illnesses frequently became demoralized. They lost hope. They thought, this is not what I thought my life would be. And they had started to not see a future for themselves. In addition, they also lost control over important elements of life. People made decisions for them about going to the hospital, or they made decisions for them about where to live or who to live with. They had trouble taking charge of things. Often young people move back with their family at the very time when they're trying to get more independent because they need the help. And thirdly, when people first get ill, the illness just dominates their life. It takes over the whole space of their life. So these three characteristics were I saw in many of these stories. People lost hope, they lost control, and they had a life that was dominated by illness, and including the sense of who they were. They kind of saw themselves as patients rather than independent people. And then the stories had this interesting change that took place. The people started to write about gaining hope, gaining a sense of that there's a future, grabbing on to the idea of what they wanted to do, starting to take control of their life, choosing, being a more active partner in making decisions about their care or where they wanted to live, and then building out a life that is much more full. Um, One of the beautiful pieces that I read at that time was by Patricia Deegan. Patricia Deegan is just a wonderful person who I've had the chance to work with for many years. When she was in high school, she became very psychotic. She was a great basketball player in our high school team, and she just started to feel terrible and feel tormented by voices. And she describes being hospitalized many times and a period of her life where she just kind of rocked and smoked. And it was a painful, stuck time of life. And she felt that the care that was being provided to her didn't see her as a whole person or didn't see the, her possibility of growth and development. And at one point, she just kind of got mad. She says that she got angry at the care and she said, I'm going to become Dr. Deegan and I'm going to change the mental health system. And it turned out that she then, not right away, but gradually moved forward, started managing her symptoms more effectively, started sorting out how to deal with symptoms, what she could do about managing symptoms. She describes uh, the personal medicine as not what you take, but what you can do to make your health go better. Um, and she started moving forward and she has changed and transformed the mental health system. But one paper she wrote talked about uh, this metaphor of a flower, a daisy. She said that when she was extremely ill, her her whole life her was taken over. The whole flower was the illness. All of her time was stuck with the illness, and all of her sense of who she was what took up all the space of the flower. And then, as she got better, her illness became a petal of that flower. And it didn't go away completely. She has to manage it. She says she still has symptoms. If she gets on an airplane, the white noise brings back voices. She has ways of managing that. Um, but the but then it started to be room for more things. There was room for uh, friendships. There was room for work. There was room for love. There was room for connection in the community. There was room for sports again. Um, so that is so what happens? So what happened in the healthcare system was that we started moving from this idea of just trying to maintain people in the community to this major paradigm shift called the recovery paradigm. And recovery-oriented care helps people to find that hope. It helps people to gain the skills and confidence and knowledge to manage their own illness, helping people to get in the driver's seat of their life, and also to get on with life beyond illness. The recovery paradigm was an exciting transformation. It changed how we thought about the work. And in our research group run by Bob Drake, who's an amazing, internationally known researcher and wonderful person, we started studying how to support people in this manner. Bob and his wife, Debbie Becker, started sorting out how to help people to get back to work who had psychiatric illnesses and how to get back to school if that was what they wanted to do. We also started to think about how do we help people to take an active role in making health decisions for themselves, because of course the person who's affected most by a health decision is the individual with the illness. So we started to think what's getting in the way of shared decision making, and how do we support people to start to be an active player in this. So one great opportunity I had was to try to go interview community psychiatrists about this topic of shared decision making. And Bob connected me with a wonderful medical anthropologist, and we started planning out. We found community psychiatrists who would meet with us in focus groups and who we could interview, and we started planning out the questions. And of course, my thought was we just start talking to them about shared decision making and ask right away. And Elizabeth Carpenter-Song, the anthropologist, said to me, no. You have to have warm-up questions. You have to get people started talking to you before you go and ask them the specific questions you want to know. And so we thought that a reasonable warm-up question for these community psychiatrists would be something like, well, what brought you into community psychiatry? How did you choose to do this kind of work? And what keeps you in it? So we did. We asked those questions, and people just exploded with comments. They just had so much to say in the focus groups and the interviews that we basically got almost nothing about shared decision making out of it. But we did learn a lot about what brings people into this kind of work. And it turns out that people that go into community psychiatry as psychiatrists or nurse practitioners are extremely mission driven. They're people who want to use their lives to make a difference. They want to work with people that may not have a, a, that really can benefit from skilled help, and they want to make a difference with their lives. They also are people that care about community. They like working on teams. They enjoy working with the nurses, with the case managers, with the employment specialists, and they like working in a town, being part of the whole system of care across a town. In addition, they are intrigued by the intellectual challenge. Each person that they meet has their own challenges. They both, what kind of medicine is going to be useful? What's their psychology like? How do you engage them? What do they want in the world? How do you help them to talk to you so that you can know them better? And so they enjoy the intellectual challenge. And we ended up writing a paper on that called "I Always Thought It Was the Real Psychiatry." Community psychiatry is a career first choice. And we found that that a lot of what draws students into working overseas and wanting to help people, the same kind of drive is what brings people into community psychiatry. So community mental health in the 1990s in New Hampshire was considered about the best in the country. Care was getting better and better, and the care that we got to do was really quite fun. One thing I liked was once a month I consulted at Grafton County Nursing Home and jail. There was a compound up there. The patients were very interesting at the jail and at the nursing home. And it was a beautiful drive. It was about an hour driving up the Connecticut River. And the nursing home always served me lunch with just excellent desserts. So I like that too. But I started looking around, and the county complex was really interesting. I started thinking, what is all this here? Why is all this right here together? So what was there? There was a nursing home, there was a jail, and there was a large farm with cows. I mean, a lot of cows and a lot of vegetables grown. I mean, there was a farm. So I thought, what is this? And it gradually dawned on me that this is what happened to the poor farm, that there was a county poor farm that gradually transformed into this. And the people that were older and not able to care for themselves ended up turning into the nursing home, and the people that were debtors or difficult in some way ended up in the jail, and the people with psychiatric illnesses that were no longer weren't able to care for themselves and needed that kind of care ended up going to the state hospital, which is now not a county function but a state function. So it made me interested in the history of mental illness care in New Hampshire. So I think I'll spend a couple minutes talking about that. So in colonial times, people who were very ill, of course these illnesses have always been around, and couldn't care for themselves, were cared for by their families, and if they didn't have families who could care for them, they were cared for by the town. The town was responsible. They'd confiscate property and use town money or money from this property to pay someone to take care of the person. Eventually, the towns and then later the counties created poor farms for people without money. They're older people, debtors, people with psychiatric illness who because of the illnesses couldn't earn their own keep. Um, the they chose to do farms because it was less expensive. People grew their own food, and it was easier to care for people together than paying for individuals to take on individuals in the town. But the towns were responsible for the cost, and because of this, sometimes if someone wandered into town who wasn't able to care for themselves, um, the town would warn them out of town. And there were laws that stated that if someone came into town from outside and was there a year and couldn't support themselves, that the town could warn them out and 7 days later take them to the edge of town and leave them. So people with psychiatric illness, of course, there weren't active treatments at that time, often lived in these very terrible conditions. They lived in asylum kind of conditions, in poor farms. They sometimes were in jail. And it led to this idea in the early 1800s that was called moral treatment. It came to the United States from people that had visited Europe. It was a fusion of Enlightenment philosophy with American Protestant piety. People like Benjamin Rush, Dorothea Dix, and Thomas Scattergood. Benjamin Rush was a doctor who started the first psychiatric hospital in the country in Philadelphia. And Dorothea Dix was an incredible crusader. She was born in Maine, and she actually was hospitalized in one of these good hospitals in England. Later, she was in Massachusetts, and she saw the plight of people with psychiatric illness who were in almshouses and prison. She made a study of this in Massachusetts and wrote up a report and brought it to the Massachusetts legislature. She was not allowed to go into the building because she was a woman, but she got the report to people and stood on the steps of the State House. She shamed political leaders into taking action. She ended up doing this across much of the country. The kind of treatment that she advocated included hospital care, that included fresh air, physical activity, educational enrichment, therapeutic farm and kitchen work, and supportive staff. These kinds of hospitals grew up all around the country. If you ever gone to McLean Hospital, which was the first one in New England, started in 1818, and Brattleboro Retreat in 1834. These are beautiful places that were clearly farms before. Dorothea Dix was instrumental in founding and expanding more than 30 hospitals in the United States. A report to the New Hampshire legislature in 1836 mandated kindness in their approach to people with psychiatric illnesses. It said the whole scheme of this moral treatment is embraced by a single idea, humanity, the law of love, that sympathy which appropriates another's consciousness of pain and makes it a personal relief from suffering whenever another person's suffering is relieved. Shortly after that, New Hampshire Hospital was founded in 1842. In the beginning, these towns and counties paid for people who were at New Hampshire Hospital. When the counties and towns had to pay, not that many people were sent because it was less expensive to keep them in the poor farms. But later, the state took on the expense. And when the state took on the expense, the counties and towns sent everyone. In the late 1800s and early 1900s, with immigration and industrialization, the hospitals got enormous. Some got Worcester State Hospital had about 3,000 people with only 3 social workers. And at its peak, the New Hampshire Hospital had 2,700 people. In the 1950s, people that had been in the hospital for psychosis had been there about 20 years, and others about 6 months. Later, these hospitals decreased in size through deinstitutionalization and trans-institutionalization. New Hampshire Hospital had a working farm until the 1970s. So, this later led, it was only in the 1960s that the federal government took a role with Medicare and disability income and Medicaid. New Hampshire Hospital developed its community mental health system starting in the 1980s, and by the 1990s, it was the best care in the country. Later, however, the system has lost a lot of money and resources were drained out of the community mental health center. Fewer beds, aging workforce, and insurance that pays so badly that health systems have to subsidize the care. Nationally, only about half the people with a psychiatric disorder get any care at all. Now, care is very hard to find. In the last several years, there have sometimes been as many as 50 adults in emergency rooms waiting for hospital beds and 20 children waiting for psychiatric beds. This happens right here in New Hampshire. The public wouldn't stand for it if it was heart disease or cancer. Outpatient care is also hard to access. We've done lots and lots to try to increase access, making it more efficient, building out skills and supports in primary care, and even learning that apps can often provide care. So I've been engaged in this very interesting work for more than 35 years in New Hampshire, and I can report that there's been a lot of good news. So here are some of the highlights. We have wonderful mission-driven people working on this issue. At Dartmouth-Hitchcock, at New Hampshire Hospital, amazing people in the New Hampshire National Alliance for Mental Illness and across the state. There are many dedicated and at times heroic professionals working in the field of community mental health, peer support, and at the VA hospitals. These are really great people. It's fun to work with them. We've had a shift in philosophy of care from that idea of maintaining people to the idea of supporting people's recovery. We have a much greater appreciation of the lived experience of mental illness and what peer support can do, and also the powerful role that families can have in supporting their loved ones and each other. People are more and more open about their experiences with mental illness and substance use difficulties, making it easier to talk to each other. And we have great medical students going to psychiatry. It's become a very competitive specialty. This year, all the slots for psychiatry across the country filled. And at Geisel School of Medicine, we currently have about 20 students who are actively considering psychiatry as their career out of a class of 90. So that's a big change from when I was in school. But I probably wouldn't be here if it was all good news. Over the last 5 years, I've had the honor to know and work with the former Chief Justice of the New Hampshire Supreme Court, Justice John Broderick. He is a family member who became extremely psychiatrically ill. The experience took Justice Broderick by surprise, and it opened his eyes to the issue. In the last 5 years, he's spoken to hundreds of audiences and thousands of people, telling them what he went through in his family, and also making it clear that no one signs up to have a psychiatric illness any more than they sign up for colon cancer or heart disease. In fact, people who've had both would rather have colon cancer and heart disease than depression. Justice Broderick says that this work, which aims to shine light on psychiatric illness, is the most important work he's done in his very storied career. John Broderick is a lawyer, and being a good lawyer, he's very good at asking hard questions that sound simple. One day he said to me, "Dr. Torrey, how would you rate current psychiatric services on a scale of 1 to 10? This question got into my head, and here are some of the thoughts that came out. Several years ago, my wife Becky was diagnosed with breast cancer at Dartmouth-Hitchcock. Dartmouth-Hitchcock found the cancer early because they have very good routine screening, and a skilled radiologist made a very good find. She met with a surgeon very quickly, and at the same appointment was connected with a social worker who offered her service as a care navigator. Becca was handed a binder with readable, relevant clinical information and resources. She was given a gift. The care connected her to support groups. The waiting room was inviting, and the environment, and in that environment, she was even given access to a massage. The care pathways were clear, and the surgery, radiation, oncology, and follow-up were all very smooth. Happily, she's doing really very well. No one wants to be diagnosed with a serious illness, but I would rate her patient care experience as a 10 out of 10. It's not impossible to offer 10 out of 10 psychiatric care. Other countries do it. Australia, for example, has invested in outstanding, well-researched nationwide care program for young people who develop psychosis and has offered and improved the services over many years. Our daughter Kay got to go to Australia and shadow some people there and came back with great stories. There are pockets of outstanding care in this country. But I think that overall, if you were to survey people in the United States today about what they found when they sought help for their addiction or mental health difficulty, they'd probably rate the health experience as closer to a 1 or a 2. Mental illness and addiction are common illnesses that often start in childhood or early adulthood and have the potential to kill you or wreck your whole life. We have care that works. This is a rich country. But in this country, it's very hard to access research-supported care in a timely manner. For many people, science-supported care is just completely unavailable to them. It really is an outrageous situation. So why is the care for mental health and addiction different than cancer care? I don't think it's just by chance. Like mental illness and addiction, cancer was a stigmatized illness. Starting in the 1940s, health activists and philanthropists like Mary Lasker went to work advocating for radically improved research and care, which eventually led to Nixon's war on cancer and many subsequent initiatives. Dr. Sidney Farber personalized care using a 12-year-old boy from Maine named Jimmy in his fundraising efforts. A huge amount of money has poured into research and care, and cancer has become less stigmatized. People now talk about their cancer. People turn up for the Proudy. Everyone is touched by cancer. A couple weeks ago, the Proudy raised $4 million for research and care for cancer. The same thing happened with HIV, another stigmatized illness. In the 1980s, a lot of people, including a childhood friend of mine, just died. And when effective medicine was discovered, access to them was extremely hard. AIDS activists got angry and they got engaged. The ACT UP protests got the world's attention. And when they protested at the National Institute of Health, instead of having the police drag them away, the director invited the protesters in and began a meaningful dialogue. The panels on the AIDS quilt in the mall in Washington, D.C. humanized the illness, as did Ryan White, Magic Johnson, and Rock Hudson. The health activism changed U.S. policy and dramatically sped progress. A few years ago, there was a wonderful art exhibit at Dartmouth Hitchcock Medical Center called 99 Faces. An artist, Linda Cottrell, whose family is touched by severe psychiatric illness, took photos of 33 people with bipolar illness, 33 people with schizophrenia, and 33 people who love them. The photos are beautiful. And of course, you can't tell which people are living with an illness. Like the AIDS quilt, it humanizes mental illness for our community. It gives it 99 faces. It gives people permission to talk about their own experiences. I think we all need to feel a bit of outrage, maybe a lot of outrage. And each of us should use our talents, whether it's artistic talent, political ability, community organizing, the ability to give money, to turn towards this clear and current challenge. John Broderick has been a modern-day Dorothea Dix, talking to many thousands of people across the state of New Hampshire, giving the message that no one asked to have psychiatric illness, and it's okay to ask for help. We need scores of Dorothea Dixes and Mary Laskers for psychiatric illness. Let's see what we can do to eliminate discrimination and advocate until the default, routine, everyday care for addiction and mental illness would generally be rated as 10 out of 10. Everyone is touched by cancer, but everyone's touched by mental illness and addiction too. People can change the world. Stigma and discrimination can be turned around. Let's talk about it and let's act. And in the future, when care is radically better, let's remember that we talked about it today and are working to make it happen. Thank you very much.
Thank you, Will. That was just a terrific talk, and I'm gonna quote one of our cousins, Helen Field, who said, "Wow, great lecture." So I would encourage anybody who can type in a quick chat or who's got a question that they want to post. I've got a couple that I'll start with, but if anybody's got any pressing questions they'd like to ask, use the chat function. Will, I'm going to ask you a question, and it's going to be probably a very obvious sounding question, but are you, I think you and I talked about this about a year ago, and of course a lot has happened in the last 12 months regarding COVID and this slog that we need to be unfortunately maybe returning to. Are you worried about the trajectory of mental illness in light of our ongoing, challenge with the pandemic? I mean, I believe when we talked last year, you were seeing obvious upticks in isolation and depression, and I'm just wondering what you've seen in the last 12 months and what your expectation is for the next 12.
Thanks, Sam. Yeah, very definitely. I mean, one of the models that, one of the ways that you think about psychiatric illness is that we all have a genetic predisposition to difficulties. Some of us, there's some people who just get depressed or just get manic with no provocation at all, and others who may not be quite as genetically predisposed, but a major stressor can bring out serious psychiatric difficulties. I think that the kind of stress that came with COVID was sort of a perfect storm of the kind of thing that brings out psychiatric illness. There was, people had health anxieties, people had isolation, people had economic dislocation, people lost loved ones, didn't have the opportunity to mourn. People were fearful for their own health, and for good reason, because people were getting sick and dying. So it's a stressor that brought out a lot of mental illness. All surveys really show that Americans got much more anxious, many more symptoms. It was really it's a very difficult blow. And then for people that had illnesses, it was harder to project care. So, we in community mental health, people do a lot of home visits. They bring people their medicine sometimes if they're not able to organize on their own, and it became dangerous to do those things. So much of the care was projected over tele. Now it turns out that telepsychiatry is really quite good. The studies overall show that people do about as well responding to over telecommunication like this as they do face-to-face, but it's still not quite the same thing, and particularly for people that need the direct care. And a lot of people who are more ill may not have the technology to really connect as well. So I think COVID has been difficult. Then in addition, just to say one more quick thing about this, for people that develop COVID, a lot of those people have long-term consequences that include psychiatric symptoms that take a while to go away. So it's the fourth wave of COVID is mental health issues, and it's not done. Our demand far exceeds our capacity to meet the demand.
Thank you. I do have a couple of questions from some names you may find familiar. From Karen Van Adsen. It is extraordinarily difficult for parents to help their over 18-year-old children, so 18-year-old children who need psychiatric help to access care. Do you have any suggestions for those parents?
Well, it's hard to access care because the care that's available doesn't meet the need. Parents can play an important role, of course, in supporting their kids and also in helping them navigate the complicated setup. I am a big fan of the National Alliance for Mental Illness. I think that each state has a chapter. In New Hampshire, it's excellent. I think the NAMI groups can help parents to sort out what's available. They can support parents who and individuals living with psychiatric illnesses. There are specific ways to look for care. Most insurance companies have websites that list people that are providers on their insurance, but a lot of times the providers don't have much room. Unfortunately, accessing care through cash practices is sometimes the only way you can get fast access. And this is the kind of thing that, I don't think it's really right that insurance coverage doesn't pay enough for care to break even, because it's very hard for services to offer care if they can't break even, and because people need to be paid.
So there's a comment from somebody else who you may recognize, Nej Christensen, and it says, "Wonderful to hear you." She says Will, so maybe she's trying to protect herself from being a sibling. But I have another question for you, Will. I think we've got a few more minutes.
Oh, just one more thing for Karen's question, by the way. Hi, Karen. The one thing when your children are over 18, they have a right to protect their own health information, so they may or may not invite you into the care. But it's a one-way right. So, for example, if you have a worry, you can always communicate with their care provider if you know who that is. The care provider can't tell you anything, but they can accept what you have noticed or know. And so sometimes that's helpful to know that you can pass on information they might not have. They might share it where they got it, but that there's no legal problem in providing information. There's only health protection and privacy protection that each of us has for a health provider to disclose information. And of course, you can disclose if you have a release.
Will, this is a kind of a related question to a question that was asked of Greg Cunningham last week, who was speaking on environmental issues in New England. I guess my further question for you would be, how do you think New Hampshire is faring in the battle to provide adequate services? And it does sound like you've got a great ally and John Broderick. But I'm just wondering if there's other New England states that you think are doing a better job, or other states in the country, or anybody's doing a spectacular job, or maybe around the world. Is any European countries that treat mental illness with an equal footing to more physical health issues?
Yeah, good question. So the way that I differentiate, just to start with, the way that I would differentiate psychiatric illness from general medical care isn't physical versus mental, because it's all in the brain, so it's all physical. But I sort of think about it as general health care versus specialty psychiatric care. But there absolutely are other countries that are doing a much better job, and those are countries that have more organized systems of healthcare, that are more centralized, that are government run, and that, because if you have that, you can really organize around population health and do the things that are optimal for the health of the population. If you look at the VA system, for example, in this country, VA is like that, right? They have a population they care for. So the VA has much more mental health and addiction care than, it's basically primary care, mental health and addiction. There's tons of it. And so you can access help for your post-traumatic stress disorder, for your depression. That's the way services would look if we were not in a fee-for-service kind of environment, more like the VA. I think in terms of states, there definitely are states that put more resources into mental health. Massachusetts, has much more resources for mental health than New Hampshire. We don't have income tax or sales tax in New Hampshire. It's live free or die, and I think their state employees are trying to do a good job. They're trying to do the best they can. We would need to invest to have really a system of care, and it would need to look different than it does now. There are efforts to do it. This doorway that has made it easier to access addiction care than it was before. That was a addition a few years ago with federal money. But the community mental health system needs great investment, and the state is currently trying to create more inpatient hospital beds at places around the state, and I think that's a help as well. But we have a ways to go to build out a system that would welcome us in when we need it, with evidence-based care.
Right. My very last question, and I'm really curious if, when you went to school for religious study, if that at what point did you decide you mentioned a suicide of a friend, but at what point did you really go from medical to wanting to specialize in psychiatry, and did the religious, at least your religious studies, which is a kind of a common family Greene Torrey vocation. Did that really play into what you decided to go into, or was it helpful, I guess would be another.
Yeah, absolutely. So I majored in religion at Dartmouth, and I took all the classes for medical school at the same time. So I was taking all those science classes and studying religion. The religion was great. Religion allowed me to think about big picture issues. What's the point of being on earth? What are you trying to accomplish here? What do you want to, help me think through? What do I want to do with my time? How do I want to use myself here on earth? What matters? Those are all issues that come up on a daily basis as a psychiatrist. You're dealing with meaning. People are grappling whether they should take their own life or live. They're grappling with the purpose of what they want to do with their time. So the kinds of things that I thought through as an undergraduate end up being critical elements of what I think about on a daily basis when I'm doing clinical care. It wasn't until medical school, though, that I even knew very much about psychiatry. So as an undergraduate, I did a Tucker Fellowship up in North Conway and hung out with family doctors and pediatricians and Meals on Wheels. And that was what made me think that, that medicine could be a job where that would stay interesting for a lifetime and that I could do in a rural environment. And that was that was really the reason I went to medical school. And when I started in psychiatry, I thought, this might be an urban profession, but it turns out, it isn't just an urban profession. And so I've had a great adult life living in the country, practicing academic psychiatry at Dartmouth.
That's great. I had one last, somebody passed the finish line on questions. So I'm going to give you one more and then we'll wrap up. This is from Lynette Mendez. May also be a familiar name. Can you speak to systems and political issues and how the potential purposeful traumatization of people of color and other under our capitalistic system? How can we find hope for ameliorating psychiatric care in the face of forces that seem overwhelmingly poised to keep people in fight or flight mode because it keeps the broken system functioning for those that benefit from the system?
Well, Lynette, that's a great question, and it's a complicated question, obviously. I think that we've learned a lot this year about systemic racism. Racism that's baked into economic structures and baked in to the history over time. I feel like I've learned a lot, and I have a lot more to learn. One of the things that it also made me realize is how baked in this discrimination is against people with mental illness, that it's in the structures, it's in the payment structures. Why is there not more mental health? It's because it doesn't pay to offer mental health care. The insurance companies don't get people fighting them to pay more for mental health so that it's available to them, because because of stigma. It's just the discrimination is baked in similar ways as racism is baked in this country. And it turns out that if you have multiple stigmatized conditions, like if you are a person of color and you have a mental illness, those kind of compound each other. So we do have a long way to go in making our country more fair. We have a tremendously long way to go in making our access to mental health more accessible. I think in some ways it's a similar kind of process that's going to be a political process over time.
Great. That's a great question. Will, guess what?
The bell rang.
The bell is ringing as we speak.
All right.
Good. I can assure you. So I guess what I want to thank you, Will, for this presentation. It was really inspiring. And I want to thank everybody out there for being such a great audience. And as a reminder, the board of the Amos Fortune Forum looks forward to hosting you next week, our speaker will be Francie von Mertens, whose talk will be on wild bees, the pollinator pros, and how we can help them in the backyards and beyond. And Will has been a beekeeper in his past life too. I'd also like to remind everybody that talks by all our past and future speakers this year are accessible via Facebook and YouTube links found on the Amos Fortune Forum. So if you've missed anybody in the past few weeks, I think it takes a couple of days for Will's talk to come back to being able to be heard again, but you will be able to catch all these speakers this year. Will, this actually is a, I have to be truthful, this is actually Vermont made maple syrup from my refrigerator, okay? However, there's a half gallon of, I'm sure, much better tasting maple syrup grown right here in Jaffrey that we will keep on hand for the next time you come visit us. So rest assured, the traditional thank you gift will be here. That's about 3/4 of the way full, so don't tarry getting here, okay? And that is it, I believe, and reserve. I don't have anything else. Thank you again. And
all right.
everybody
Thanks,
else.
Sam. Bye-bye.
Take care.